In this program, we try to demonstrate how to set up and execute AMS program in a hospital setting. We would like to share the experience of AMS from Chi Mei Medical Center. Antibiotic stewardship is one of the most important issues for hospital infection control. However, to face the constant emergence of various multi-drug resistant microorganisms, judicious use of antibiotic and the effectiveness of antibiotic control execution need to be reviewed and improved all the time. The efficacy of antibiotic in different kinds of infection compared to the efficacy of the thrombotic therapy or aspirin used for the heart disease. For community-acquired pneumonia, the mortality rate of pre-antibiotic era is about 35%. The mortality rate for antibiotic era is around 10%. That means 350% changes in mortality rate without antibiotic treatment. For hospital-acquired pneumonia, the figure is about 60%, 30%. That means 200% changes in mortality rate without antibiotic treatment. For high infection, it's around 100%, 25%. That means 400% changes in mortality rate without antibiotic treatment. For central nervous system infection, 80%, 20%, and it means 400% changes in mortality rate without antibiotic treatment. For skin infection, the figure is around 15%, 0.5%. That means 2,200% changes in mortality rate. For the use of aspirin or thrombotic therapy for heart disease, without treatment, the mortality rate changes 165%. In general, we think the use of aspirin or thrombotic therapy for heart disease is a gold standard. From this slide, you can see that the antibiotic is just like a magic bullet for infectious disease. But even though the antibiotic is a kind of magic bullet, we still should use it very cautiously. The 5 Ds of antibiotic stewardship. That's the 5 most important elements for AMS. Diagnosis. Does the condition require antibiotic therapy? Drug. Is the bacteria susceptible to a specific antibiotic you want to prescribe? Dose. What is the recommended dose? Duration. What's the recommended duration? De-escalation. Can the antibiotic be switched from IV to oral form? This slide shows the process of prescribing antibiotic. The computer system will guide the physician and remind the physician the process of prescribing antibiotic. The computer system will try to remind the medical doctor to review the symptom signs and to correct the suitable specimen and refer to the guideline for the medical doctor to prescribe adequate antibiotic. And even the computer system will assist the medical doctor to calculate the suitable doses for the medical for a specific patient. Of course, the computer system will provide the recommendation and suggestion, and the in-charge doctor should need to make the final decision. This slide is about the detail of the prescribing antibiotic process. When a physician need to prescribe an antibiotic, the computer system categorize the antibiotic into first, second, third, and fourth category of antibiotic, which I will go back earlier, later on. And the computer system information need the physician to key in the reason for prescribing a specific antibiotic, and then do the dispensing and for the review of antibiotic. And for the monitoring system, pharmacist or ID expert try to do something for the review. And the computer system also provide the reference for the prescription of antibiotic, such as we suggest duration, we suggest provide guideline for JMII, which is a famous publication from Taiwan Infectious Disease Society, and also treatment guideline, local or national guideline, and also provide the insurance policy from Taiwan, and also remind the doctor to do the laboratory examination, dosage check, and remind the doctor to do the consultation, and also provide the consultation reply or feedback from the ID expert. So before make accurate diagnosis, they provide this kind of information, try to remind medical doctor to check if the patient truly have any symptom sign of infection, such as body temperature, heart rate, respiratory rate, and fine blood cell. Are there the patient, do the patient have a symptom sign of sepsis or septic shock? And also remind the medical doctor do what kind of examination. This slide can very simply differential virus or bacterial infection. For example, for the URI, no need to use antibiotic because it is a viral infection. For the perforated bowel or necrotizing fasciitis, it's for sure a bacterial infection. Aside from antibiotic treatment, they also need to do the debridement. So every doctor need to know the most common bacteria by site of infection according to the epidemiology data in local area or in your own hospital. Before giving any antibiotic, they need to do pre-antibiotic microbiology test, such as biochemistry or microbiology data. They need to collect a specimen for culture, for smear, gram stain, HFA stain, for antigen or antibody test for PCR, and also radiology examination, such as chest X-ray, KOB, echo, or CT scan. You may wonder what's the importance of culture. This slide shows if you do the culture before antibiotic, 31.5% of the pathogen can be found. If you do the culture after antibiotic, only 19.4% of the pathogen could be found. This is about the first line and second line antibiotic from the Bureau of National Health Insurance Company, Taiwan. They have a classification for the first line antibiotic. General practitioner can make clinical decision and antibiotic use. And the second line antibiotic, any doctor can prescribe a specific antibiotic with a specific reason. Okay, for the IV form, that's another category. And in some hospital, for the first line, only specific doctor, such as chairperson of the infection control committee, can prescribe the antibiotic, not by any other antibiotic, not by any other physician. This is a local data, local reference from Chi Mei Medical Center. That's only for Chi Mei Hospital doctors to use. And the ID physician or pharmacist try to check the information, so check for the cultural correction, inpatient consultation system duration, or consultation reminder. That's only for the monitoring of the rational use of antibiotic in a hospital. This slide shows the detail how the computer system assists the medical doctor to calculate the suitable dose for a specific antimicrobial agent according to patient's renal function and liver function or body weight. Next slide. Actually, drug-drug interaction in patients with renal function impairment is quite different between patients. So before use antibiotic, you need to consult pharmacist or ID expert for different kind of infection, different kind of antibiotic. And for the patient with liver disease, use of child-proof score is very important for the patient. The slide show the stand or show duration for different kind of infection. For example, uncomplicated UTI, maybe 3 days is long enough for the short course of uncomplicated UTI. But for the intra-abdominal infection, it may take 7 to 14 days for the treatment. After initial appropriate broad-spectrum antibiotic regimen is prescribed, modification of the regimen with a de-escalation strategy should occur on the basis of patient's clinical response and the result of microbiology testing. Next slide. The following is several cases of experience from Chi Mei Medical Center. This patient suffered from long-term fever, and they have an underlying disease of liver cirrhosis. So it usually it is a kind of FUO, fever of unknown origin. The examination we done for him is a getting scan, CT, cardiac echo, T. You can see the fever pattern, low-grade fever for a long time, and the blood culture show gram-positive oocyte. We use oxacillin for empirical therapy. And the following blood culture still grow gram-positive oocyte that is Staphylococcus for a long time. At this point, do you want to change any antibiotic use? The the physician shift to vancomycin. So after a serious examination, it shows that abscess formation for the spine. So that means a bone metastasis, that the staphylococcus infection, and it did metastatic to bone. The second case, that's a UTI cases where with low blood pressure and a high temperature and higher pulse rate. So the blood culture show is a KP, bacterial culture show KP, and it's sensitive to almost every antibiotic. So we try to change antibiotic. We try to risk escalation for this patient. Case 3 is a patient with a local wound, a fever, and right hand pain for 3 days. For this kind of infection, we need to check the local wound first, and then try to ask about the trauma history, any kind of animal bite. Or there are some typical for figure here. The first one is a fish injury that may be due to vibrio bonifex. The second one is a dog bite. I think it's a kind of mixed infection. The third one is a snake bite. Is also a mixed infection. For a case, underlying situation is DM, chronic pancreatitis, alcoholism, liver cirrhosis. The patient have a history of right foot swelling for 3 days with hemorrhagic bullet. You can see the photo here. That picture is very very prominent, and he had a history of lowest consumption. The blood culture grew vibrio bonifacus. The drug of choice for seawater exposure is third generation cephalosporin plus minocycline. That most prevalent pathogen is vibrio bonifex. If the patient have the seawater exposure, the bacteria, the involved bacteria may be Aeromonas species. So the patient's history is very important. For necrotizing fasciitis, if patient have seawater exposure, we suspect vibrio bonifex might be the principal pathogen. So we need third generation cephalosporin plus minocycline for the treatment. For freshwater exposure, Aeromonas might be the pathogen. Quinolone might be drug of choice. If the patient have the similar symptom without seawater or freshwater exposure, probably penicillin or clindamycin will be the drug of choice. And other than antibiotic, when debridement or amputation may be indicated. So in conclusion, for infection control for AMS, the hospital director need to assign a capable chairperson for infection control committee. And they also need to involve information technology, hospital epidemiology, infection control professional, clinical pharmacist, and clinical microbiologist, and infectious disease expert need to be the member of the infection control committee. It's a team approach, and they need to communicate each other. That's infection control is a teamwork. It's a success for the AMS. Thank you very much for your attention.